Here we go.
Okay.
Good evening, everyone. My name's John Daw, and welcome to COVID-19 Town Hall Week 13 with Dr. Sanjay Udoshi. I am live here from Wilkes-Barre, Pennsylvania. Sanjay is live here from Shavertown, Pennsylvania, now about, 5 miles that way, because I am at a different location this week. Welcome. We are excited to have everyone here tonight. Once again, for those of you, this is your first time joining us, we have a chat session. We're asking you to please not use the chat session to submit questions this week. There's a Q&A button with little thought bubbles on your screen. You can use that to submit your questions, and Karen will go through those and pull those out as we get them in. Let's see, we have a bunch of people with us tonight, so let's just get started. Sanjay, go ahead.
Great. Thank you so much, John. I can't believe we are now at week 13 of doing this. I hope it's been useful and helpful, and we thank everyone for continuing to come and visit with us every week and talk to us about their observations and bring their questions forward. John and I have gotten excellent feedback, a lot of positive feedback from a lot of people across the country and also across the world that are appreciative of the conversations that we're having, the questions that are being brought forward, and the information that we're able to provide you with so that you feel a little bit less anxious and a lot more safe about being in this era of having COVID in our societies. So this is going to be somewhat of a shorter town hall session. There is a lot of news, but I'd like to focus on a few items that are of extreme concern. I'm going to just share a screen here. I hope everybody can see this. How do I just slideshow? Okay, so one of the things that we have to recognize is that the first wave of COVID is most definitely not over. And I'm not just speaking about in Asia, Europe, or the United States, because the news is coming in that Brazil and Russia have surging amounts of cases, especially Brazil and Latin America. And this does not represent a second wave of this pandemic. This is still the first wave. And what that means is that globally, we have not contained or controlled the spread of COVID. And even though there are very few stories of success, such as New Zealand and Taiwan and South Korea, the majority of countries have not successfully contained COVID. I would say that the numbers in Europe are looking excellent, except for the United Kingdom, which is continuing not to have adequate control. But Italy and Spain, which were very, very hard hit early in the pandemic, are beginning to see their numbers improve vastly, and their economies and societies are able to open up with greater amount of confidence, as well as for the reason of having a national testing strategy that allows them to be confident of identifying any outbreaks or resurgence early on. Same is true in Germany. So if this continues, if there is a lack of containment for the next 3 to 4 months, the pandemic will be compounded in severity by the fact that there will be a return of the influenza season. So it will be hard to differentiate some of the symptoms of COVID from the symptoms of flu. Flu affects the young and it affects the old. It seems that COVID has tended to affect the adult age groups of 35 to 65 with flu-like symptoms, but it has been a killer. There is no other word for it. COVID is a killer of those over the age of 75. So why have I put up this analogy of peeing in the public pool? If we don't have a national containment strategy, a national testing strategy, et cetera, we will continue to have states like Arkansas, Texas, Florida, South Carolina have resurgent spikes of infection that can then spread to the states that have exerted control over the initial wave. So the second wave will not be from baseline. We will not return to a state where, the nation is seeing less than, 10,000 new infections per day, 5,000 new infections per day, 2,000, and then subsequently to the hundreds. Right now, we continue to see our numbers hover around the 20,000 mark, and this is a real problem. So if we, the graph is obvious. I want to keep showing graphs, but the graph is the United States went to a surge of about 35,000 or more new cases per day at its peak, and at the very top it was about 47,000. It's come down now significantly to level off at around 20,000. So on some days it's 18, on some days it's 21, but we persistently have 20,000 new cases per day in the United States. And that's really unacceptable. The reason is, again, we covered these numbers, we have covered them every week. 80% of the people who get this disease are going to recover fine. 10% to 12% are going to recover, and they're going to carry with them some damage from it. 8% are going to go through the most severe form of the disease and may require hospitalization and then subsequent escalation to critical care. And then among those that go to critical care, 1.5% to 2% are going to die, regardless of their age group. If you're above the age of 75 and you require hospitalization and critical care, your fatality rate or probability is around 15%. So 15% of all those cases above the age of 75 that are hospitalized or require critical care will die. That's 15 out of every 100, 15 out of every 100 grandmothers, grandfathers, people in that age group. So when you have 20,000 new cases a day on average and no containment or control over that, group, then you will continue to see significant amount of death. And when we already have lost 40,000 or 45,000 and growing elderly in this country, we're going to see a lot of more unnecessary loss of life, and we need to figure this out. So let's go back to my screen here. All right, so last week we talked about how the WHO had to walk back its a silly misstatement on asymptomatic spread of SARS being rare. COVID being rare. That is absolutely not the case. Evidence and you guys know that there's the papers that I read every week. So we're looking at 40% of every transmission. 40% of every transmission comes from a person who is not exhibiting any symptoms or is pre-symptomatic. So I come in contact with someone, I carry it for 4 to 10 days without even feeling no illness. I go to the grocery store or to another store, or I go to work, And even though I'm social distancing and masking, there is an opportunity for me to shed and spread the virus, even though I'm feeling perfectly fine. And then maybe on day 12, I do feel ill. And I spike a fever of about 100, 101, but I get better soon because I'm in the 80% that really don't have a difficult course of disease. And so I get over it. And then 14 days after I get over it, I'm still shedding. I'm still shedding live virus. This is what we know about COVID. And this is the danger of it. And so 60% of the spread is definitely from contact. So I'm going to tell you a story today that's going to be very troubling. And the reason I need to share this story with you is probably you've heard this happen to someone you know as well. And it is the absence of guidance that is causing this. One, we have no clear testing strategy. We continue to tell people who are asymptomatic that they don't need to be tested, which is not true. And we're seeing variable usage of masks, even though the evidence shows that as soon as the pandemic reached South Korea and other countries in the Asia, Pacific, and they implemented the guidance of mask usage, which is, especially Japan, South Korea, Taiwan, Hong Kong, Singapore, Malaysia, and now New Zealand as well, and that included in that group of nations, implemented mask usage or guidance for mask usage immediately. They saw a 70 to 80% reduction. In Austria, which was obviously part of the first wave in Europe, they actually implemented mask usage and within 2 weeks saw a 90% reduction. Rocket, you guys are driving me nuts. Excuse me, 1 second. Out. Out. Out.
His menagerie is acting up.
Okay. Hi. Sorry. All right, that's what happens when you have 4 dogs. Anyway, so when there's no clear testing strategy and there's no guidance on masks as a national strategy, what happens is you have some people that feel like their section of the pool, the public pool, is where they're allowed to pee. So, that's ridiculous, right? There's no public pool that has a peeing section. But right now, I'm sorry, Terry, Texas and Florida and Arkansas and South Carolina are the peeing sections of our public pool in the country. And what that means is, and other parts that where mask usage is not ubiquitous and mask usage is not being pressed into practice, that is causing us to continue to see 20,000 new cases a day. And it's no longer funny or acceptable. I don't want to discuss the politics of it. All I will say before I begin my story that I heard that I want to share with you is that even some of the best healthcare systems in the country are implementing their own protocols, and by doing so, they are they're doing it in a way that is useful for their population health and is tuned to their population health. But when they do that and they ignore a national or international standard, it is going to cause the further spread and the lack of containment that we see. All right, here's the story.
Sanjay, before you go to the story, can you just back up the bus on something that you said? So Sandra just wanted to make sure she heard right. You said that you can still spread the virus even after you heal?
Yes.
What was that time frame again?
Okay, so let's say you come in contact with someone that has the virus. We don't care about whether they're sniffling and sick or not. Let's just say that you get exposed and that the period of time between you getting exposed and you feeling sick can be as short as 2 days, okay? Or 4 days after you get sick, after you get exposed, you may not feel sick at all. You may continue to feel well, but you are infected, okay? And then from day 4 to day 10, on average, is when people are in that asymptomatic carrier or pre-symptomatic date range, okay? During that time, before you feel the fever and cough and any feeling of malaise or illness, you can be shedding. That is called a pre-symptomatic or preclinical phase, okay? Now you get sick, all right? You get a 101 fever, you get a nasty dry cough, you get a little bit of body ache, and you take your Tylenol and you eat your chicken soup, and 2 days later, 80% of people are fine. They feel fine. That's COVID for 80% of people. Now, in this post-fastigium, which we call, that's the date, okay? The date of you feeling better. From that date, for the next 10 to 14 days, you can still shed live virus. That period of time is when your body is producing antibodies and clearing. It's clearing virus, okay? So it's still shed. So that pre-symptomatic phase is the viral titer rising to a point where it can spread to your body and rest of your respiratory system and make you sick. So it's the virus replicating in your upper respiratory tract and then getting to the point where there's enough of it to make you feel sick. All right. Then the body responds. You get your illness and fever. It goes away in 2 to 3 days for 80% of the people. And this is people who don't seek hospitalization. They don't feel like, I'm serious enough to go see a doctor. I'm just going to stay home. I'm going to eat chicken soup, stay away from people, cough and sniffle and fever it out. And once I feel better, I feel better. But then a lot of these people are not going to go get tested after they feel better. Okay? And then they will not know that they ever had COVID. And they will go out back to their routine. And during that post-fastigium, the period of time where after they feel better, for 10 days after they feel that day of feeling better, 10 days to 14 days, you can still shed. Okay, I have to look, but I have the paper on it. So yes, it's absolutely the case here that we can see that post recovery shed and then pre-symptomatic shed. Both of those occur. All right. What was I going to do now? Oh, the story. Okay. All right. So a nurse that I worked with at Geisinger, who's a good friend of mine, she has been working locum and other places, travel as needed in the Harrisburg area. But her home health system is Geisinger. One of her close family friends called her and asked, a bunch of questions. And she's like, you know what? You should really talk to Sanjay because I don't know the exact answer to this stuff. So this woman called and she said, last week I got to go back to work and I put my 11-month-old in the daycare that was just allowed to reopen in my county. So her 11-month-old boy was in daycare for, I think, maybe 6 hours a day, for the morning and then the afternoon nap time and all that stuff. But it was there for 5 days in a row. On Thursday or Friday of that week, so starting on Monday, daycare Tuesday, Monday, Tuesday, Wednesday, started on Thursday and got really coughy and sniffly and just, she got worried. She took him to the urgent care center after she picked him up on Friday. And they dutifully, thankfully, the Geisinger urgent care system tested him, okay? So he had a fever on Saturday, Sunday, and then on Monday they called her and said, your son tested positive for COVID. And if his fever goes above 102, we need you to bring him in. We might need to, observe him overnight and stuff like that. But if you keep checking his temperature every hour, and if it goes over, bring him in immediately. Great, good guidance, great pediatric system. Love Geisinger. It's my home system. Good to go. Okay. Problem with that is kid starts to feel better on Tuesday. No fever. Okay. But no follow-up from Geisinger for the rest of the family. How many people live in your household? Are there any elderly in your household? Who has he been in contact with? Can we call the daycare center and find out the names of those who work there? Okay. This is called track and trace. All right. Because now we have a positive kid in a household with an elder teenage sister, all right, who just tested positive yesterday. All right. And the only reason they got tested is because I told them to. So father works in a factory, okay, 3 feet away from dozens of people for an 8-hour shift. Told him to go get tested because Geisinger wouldn't test him. Mom got tested, wouldn't test the dad. Okay. Mom tested negative, but that was the day after. So that was Monday. Yeah. So it was the day after the kid started feeling better. So she could be in that 4-day undetectable. All right. So I told her she got to get tested again. I'm sorry, Mom. All right. But this is it. So why is this important? And so daughter tested positive was Friday. So Friday. I've been monitoring them for 7 days now. So so she talks to me today and texts me today and says, so yes, forgot to mention the daughter, 14 or whatever years old, had sniffles and a cough and a mild fever, but got over it. Is she allowed to can she go back and, whatever, do her thing as a teenager? Like, actually, no. But if she has to stay 6 to 12 feet away from anybody that's outside of your household, and she has to be masked. Otherwise, she's going to potentially give other people COVID. All right. No one from the healthcare system that detected a positive test reached out to these people and asked them these questions. And where does dad work? Where do you work? How many people work in daycare? Were they tested? Is the daycare still open? Can we talk to the owner? Can we? You just found a nidus of infection. Come on, man. What are we doing? So this is bullshit. National testing strategy. Because nobody's been given the guidance to do this. Clearly, nobody's doing it. And I'm not trying to brag about Geisinger is one of the best, it's the most IT savvy, evidence-based medicine, standard of care places, at least in the state. It's one of the best, if not the best when it comes to population health. There's better centers like UPMC and the fancy university places for the fancy stuff. But when it comes to primary care medicine, primary care pediatrics, Geisinger sets the bar nationally and wins awards nationally every year. If they're not doing it, what's going on in Arkansas and South Carolina? So, and they're going to continue to pee in the public pool. And we're all swimming in it. So, okay, go ahead, Terry.
Yeah. Without getting too political, there was a statement made in local government here about how the 20-year-olds are not taking this serious. Mm-hmm. It's the one group of people who are actually taking it more serious, at least from what I see, 50 and up, it might as well not exist. I mean, it blows my mind. I'll go into the store, I'll be all masked up, and there are people walking around like, hey, it's just another day, summer's here, woo woo.
Yeah. I'm amazed, proud, happy to see that when I go for coffee in the morning at 6 or 7 a.m. down to the convenience store, you know, working class guys that are out ready to, you know, go mow lawns and cut stuff down and build stuff and, you know, clean gutters, they're all masked. Like, oh, bravo. You know, Back Mountain of Wilkes-Barre, Pennsylvania, which is, you know, I don't expect them to be big lovers of Dr. Fauci and others, but they're listening and they're doing it. There's no reason not to. And we got guidance from my school, where the boys go, okay? And I'm on the board of the panel of the pandemic coordination, whatever, safety and health and safety plan. And it's beautifully done. There's 5 doctors that send their kids to this school, and we've all collaborated. And we know that the kids aren't going to be able to wear a mask for 8 hours a day. Okay, so we've got to do other mitigation things. You can't ask a 3rd grader to wear a mask all day. So you got to do the testing. You've got to do the trace. You've got to do the family education. You know, it's all this stuff. So the mask isn't end all be all either. It's a combination of some basic strategies to keep this from ballooning out of control, or from keep it from just persisting. Persistence is the problem right now. Italy's curve looks like this, okay? Our curve looks like this. It's on declination, but declination from 35,000 cases a day to 20. That's not major progress. Major progress is, you know, Lombardy hasn't seen a death in 11 days. Okay, they detected 15 cases in all of northern Italy, you know, last week. That's progress, not 20,000 new cases a day. We are not there. And mom has been the mother has been diligent about getting the daughter tested. The husband didn't want to get tested. She's like, you got to get tested. Rite Aid in their region wasn't doing the free ones that we have here in Wilkes-Barre. Our Rite Aid does free. And John's going to tell us about his experience with that. I think now is probably a good time. John, you want to jump in?
Sure. So it was a real easy experience. I signed up online, a whole process. Man, I guess if I would have read the 18 pages of disclaimers I had to agree to, it's sort of like when you install Microsoft Word and you have 18 pages of end user license agreements to go through. But I suppose that would have taken a while if I had read the whole thing. But I went to the privacy stuff. I'm like, okay, this is cool. Signed up. They sent me a time, or they sent me 3 times. I picked one. If you've ever done a drive-through pharmacy, so if you've ever gone to Walgreens or Rite Aid and picked up your medicines through a pharmacy window that you drove through, then it's real easy. You drive up to that window. They confirm your name. You show them your driver's license. You hold up your phone with the appointment number on it. They say, oh, here you are. They take this bag. They drop it in the drawer. The drawer comes out to you. They say, stick this thing up your nose for 15 seconds, and they count the 15 seconds. And then they say, now take it out and stick up the other nostril. They count 15 seconds. They say, put it in the tube, screw the top on the tube, drop it in the bin. You're done. You'll have your test results in 3 to 7 days. You
Cool.
Drive off. You don't get out of your car. There's no real contact with anyone. They're masked. They have gloves on. They send your kid out, and you send it back.
Cool. Now
I'm laughing because this apparently is the week for the Sanjay crew and cast to get tested, because I got tested too in the drive-through.
outstanding.
And
So do you have your result yet?
yeah, I got my result within 2 hours. And then my family was so fired up that it was so easy that they decided to go the next day. So So Rob went, and then my stepdaughter went, although she's been getting tested all along every week because she works in a nursing home facility.
Okay, great.
But she wanted to get an extra test too because her friend of a friend had it, and then they got all paranoid. So as long as she qualified and it was free, she went for it. So father and daughter went together, and it's the exact process that John just detailed. But ours was a little bit faster. It was done at a Walgreens.
Okay, so I have two questions. One for you, Karen, and then we'll go back to John. So what prompted you to get tested? You wanted a baseline, or you were exposed?
You're going to make me confess now, aren't you? All right.
You went to a protest.
I went to a protest. I did.
I heard that she went to the gym.
Why didn't I think of that?
I was told that she went to the gym.
Okay.
I went to a protest, and I asked you last week, what's the window?
Yes.
I was asking that for someone that I know, which was me.
Okay, great. No, good. So you probably had the Abbott ID test, and that's good. That's very good. We realized that the error with the Abbott ID test was the way the sampling was handled. It wasn't the test itself. So you're in good shape. All right. So John, go ahead.
I do have a serious question about a regular that dials in all the time. It's Heather.
Okay.
And if you remember, Heather, are you there? Do you want to ask? Her husband is sleeping in the garage right now, so you can guess what happened. So she does have a kind of a serious timing question. Heather,
okay.
did you want to unmute and ask yourself?
Okay, hello.
Hi, Heather.
You can't see me though, right?
No, we're
Okay,
in the webinar
God.
format, so I can't. Okay, go ahead.
Good.
I mean, we can if you'd like.
No.
Okay.
No.
Okay.
So yeah, my husband works for AT&T. He went into a house yesterday, and the husband and wife were arguing, and he could kind of hear certain things, and he realized that the guy kept telling her to go back to bed, that she's sick. So he asked the guy, was she tested for corona? And he said, oh no, it's just a flu. And so he hurried up and finished his job. And as he was leaving, the woman had shouted out to him, he should have told you I had COVID. And so obviously it was a super fun night last night. And he couldn't get any clear answers. He tried calling our city's health department, our county's health department, COVID nurse line. None of them really had any advice to give that had any kind of outline. You know, it's almost like they're just making it up as they go along.
Okay.
And so we kind of took bits and pieces of all of it and our own common sense. And we live in a small house, so he's kind of camping out in the garage. We weren't sure how long he should do it. He's gonna get tested on Friday. So this happened on Monday. We have free testing that's going on at a high school up until Friday.
Okay.
So he was gonna go and do it on Friday.
Perfect timing.
Do you think so? I didn't know if he should wait another day or two, but
that's perfect.
And we don't know how long he should be out there, and you know, we're not coming within 6 feet of him. We put masks on. If you know, I'm bringing food out and putting it on the stoop, and like I'm feeding a stray cat.
Okay. All right. So was he wearing a mask when he was working in that household?
He was wearing a cloth mask, and the other guy was wearing some kind of face covering as well. The concern is that she obviously kept getting up, so we're assuming she's been up and around the house, and you know, when he's in there doing work, he's touching things, you know.
Yeah. Okay. Yeah. So the risk of contamination is high. I'm not going to lie. It's, you know, it's not like this is something this is a high risk scenario. So your precautions right now are warranted. He can obviously come in the house. He can come into your house for showers and all that stuff. He can even, just, you need to do try to stay more than 6 feet away and be masked up when both of you are anywhere close to each other until he gets tested.
Okay.
But yeah.
So even though he never came face to face with the woman, like he didn't even ever see her, she was up on the second floor and he was on the first floor.
Right. So the problem there is we don't know what kind of airflow that household has.
Yeah.
We don't know, like, if she's been coughy and sneezy or whatever, flu-like symptoms. So Dr. Kim Prather is the foremost expert on aerosolized transmission of infectious disease. You work a lifetime to be one of those people. So she presented that it could be as few as 5 droplets, and the droplet size is less than 5 nanometers. So, anything that she coughed up could hang in the air for 2 to 3 hours, and
it's still living on surfaces, right? I mean,
again, we're looking at a few hours here, 3 to 6 hours on surfaces, maybe 2 to 3 hours hanging out in the air.
Okay.
But if he's walking through that environment, even if he's got his cloth mask out, it could drop into his eyes. It can just hang out on his skin. You're just in a high risk environment. It's the equivalent to walking through a COVID ward. If you don't have the right PPE on, right?
Yeah.
And then we have a procedure in healthcare. We, donning it in a zero contamination environment, going in, coming out into a contaminated environment, doffing it, and all that stuff. He walked in with his work clothes and a cloth mask on, and then walked out.
Yeah.
So there's no guarantee that he got it, or there's equivalently no guarantee that he didn't, right? There was clearly a high risk of exposure there. So the best.
I'm sorry.
Go ahead.
When is the cutoff where we can stop worrying about him getting symptoms?
10 to 14 days.
Oh, okay.
Yeah. I mean, 10 to 14 days is average.
If his test comes back negative, the one that he takes on Friday, then is he in the clear and they can go back, or should they just be extra careful?
I would just say until the 10th day post-exposure, he should try to stay away from you guys and mask up. That's about it. Just to be like ultra safe. I mean, I don't want him sleeping in the garage for 10 days, but at the same time, like if his test comes back negative, fine, back in the house, but he's keeping distance from you guys.
Okay, but he should stay in the garage until we get the negative. He is comfortable. It's like a man cave, so it's not like, it's not horrible.
Okay, because the only problem is what would happen is if he comes into the house and then he's isolated in the room, that room is then contaminated, potentially. Right? Yeah. But if he's in the garage, just open the garage door, right? And whoosh, it's going to kind of clear itself out in a couple hours.
Yeah, we're lucky with good weather right now.
Good.
Thank you.
Somewhere in Racine, Wisconsin is a man in
So you're another
garage.
person I'm going to have to follow up with on Friday. I will.
Yeah.
Sanjay, Racine is a hot spot. So it's inexcusable that she couldn't get guidance.
Right now it's 3% fatality rate.
Ooh.
And last week it was 20% positive rate. I think that came down a little bit, but still that's crazy high.
That is very high, yeah. That's very high. At the height, it was 57% positivity rate in New York, at the height. So you're on the declination at 20%, that's really high, very high.
Yeah.
Technically a hotspot.
Okay.
Do we have any questions?
Okay. Thanks, Heather. We do have a question from Facebook. I'm going to adjust that. There you go. Can you go over the comments from last week regarding people who test positive but have asymptomatic COVID-19? but don't have antibodies. Is this confirmed or is it a working hypothesis?
Hey, where's my paper? Here we go. COVID-19 antibody tests raise as many questions as they answer. And this is a beautiful paper. I'll send it to Terry, and Terry can post it on the page of the group. So it's a beautiful paper. I mean, it's just it's written from a layperson perspective. It's not a bit, there's a little bit of technical stuff in there, but it's not. Anyway, the point is this. You know how I said about 40% of people will carry this without ever knowing it, and then the rest of the 60% who are the transmission mode that we just heard about from Heather. Okay, you are exposed directly to a person who's sick or indirectly to a person who's sick. Okay, in the case of Heather's husband, it's indirectly, right? In the case of that woman's husband, it's directly. She's sick. He's probably going to test positive at some point. Whether or not he gets the same course of disease, it's, okay, so we have that breakdown. All right, now, let's talk about those people who carry it and don't get the illness, the COVID, right? The coronavirus disease, right? So what is coronavirus disease and what's the symptomatology? Starts off with fatigue, dry cough, feeling of malaise, mild to moderate fever, topping out at 102, and then in the severe cases 104, even higher. Okay, all right. But let's talk about mild. Let's talk about people who just carry it and get a cough for a couple days and then they're over it. It's more than likely what that is the infection of SARS-CoV-2 virus in only the upper respiratory tract, okay? So in the upper respiratory tract, there is a significant amount of what we call innate immunity deployed. So what is innate immunity? There are antibodies that are produced that just sit in your mucous membranes. And their purpose is to capture the viruses and bacteria that are most commonly encountered by your body, okay? So they capture them, they're an alerting mechanism for the white blood cells that hang out in these membranes and in the vasculature around the face and throat, nasal passages, etc. And what those white blood cells do is they just capture them and kill them and move on. There's no alerting of the whole immune system, okay? The T cells, the B cells, the whole adaptive immunity that comes along with getting sick from something like an E. coli infection or the flu or other bacterial and viral infections. So there's two types of immunity, innate and adaptive. The people who just have this little symptomatology or they don't even notice that they're carrying the virus, what's happening is that virus has not taken hold enough or replicated enough to go down into their lungs and cause classical COVID, right? So in that case, in those 40% that just get over it without classical illness, innate immunity has taken care of the virus. What does that mean? That means that in those 40%, when we test them for antibodies, it's most likely going to come back negative, okay? In the 60% that advance to, okay, I had this cough and cold and then I started getting kind of discomfort, fever, malaise, had a little bit of trouble breathing when I walked upstairs, that kind of stuff, right? Classical COVID symptoms. If they get over that, and most likely, because it has descended into the lungs and it has activated T cells, and the body has recovered through the mechanism of addressing the virus by activation of T cells and B cells and production of antibodies to clear that out of the lungs, etc., they're going to test positive for antibodies, okay? So with that description, I'm going to let you follow up with anything that you might want clarification on.
Yes, actually, there's two questions out there, and then we're all caught up.
Okay.
Carol has a conundrum.
Okay.
So she is in California, and she needs to make her way to the East Coast.
Mm-hmm.
So that's quite. She suspects that driving is the safest, but that's quite a long drive.
Yeah.
So she's going to need to get on a plane. She's
Yep.
worried about the circulation on the plane. What should she do when she goes into the lavatory?
Okay.
Sanitize all points of contact, bring her own food. She's going to mask on the plane. Is there anything you want to add about trying to fly?
Sure.
And she's going to be flying in September.
Oh, okay. All right. So we should have better protocols by then. But the advice that I'm giving right now for anyone that has to fly, including a classmate of mine who's a pilot who called me for advice because clearly nobody's working at the FAA or CDC to issue advice to airline pilots and crew. Anyway, so what I told him was that, your likelihood of transmission increases with one, duration of exposure, and then obviously, let's just call it amount of exposure. Okay, what is duration? Duration is I'm going to sit somewhere where there are potentially a number of people either sitting with me or coming through the environment, and I'm going to be there for an hour. Well, my duration, my risk of transmission, risk of getting it, increases with every hour that passes. It literally increases with every minute. So if I sit there for an hour, it's a lot less than if I sit there for 5 hours. Okay, so an hour and a half to 2 hour flight, less risky than a 5 or 6 hour flight. All right, that's one thing to consider. Second is embarkation, disembarkation. So if you have to transit through a couple of airports, like if your choice is to fly from LAX and then stop in Detroit and then have to stop in Charlotte to get to Newark, not great, right? Because then you're getting off the aircraft, you're getting on another aircraft, you have to walk through crowds, etc. So if you have a long haul, you should try to take a direct flight. One aircraft, one embarkation, one disembarkation, right? Minimize the amount of risk when it comes to environments that you have to transit through. Duration and then amount of exposure. All right, does that make sense? All right, so when it comes to precautions on the flight, again, don't wear gloves and don't worry about that stuff. Make sure you have hand sanitizer. And cloth masks, in my opinion, are not enough for aircraft environment. Unless the aircraft is sufficiently disinfected at every opportunity, landing, taking off, after landing, before embarkation, right after disembarkation, all that stuff. And then there's some sort of circulatory air circulation disinfection protocol. We used to see that a lot on international flights, especially where countries had different agricultural protocols. So they want to prevent certain infectious diseases to non-native, things like that, things that could potentially, so you're flying to an island that has never seen a certain bacteria or virus. They'll disinfect that plane so that you're not putting that island and its wildlife at risk. We used to see that a lot, and I think we still do. I haven't been to many tropical islands recently, unfortunately, but but it happens. So are we doing that here in the United States? Most likely we are not. So what you would want beyond I would not recommend your cloth mask like John just had on. I would get an N95. Okay, so the ones that healthcare providers use for shifts when they have a high risk of exposure, you should then take the same precaution. You have a high risk of exposure. You want something that's going to seal well across your face and is going to be sealed for the duration of the flight. As soon as you come off the flight, you want to take that off and put a cloth mask on, that's fine. And transit out of the transit out of the airport. Once you're out of the airport and with family, take off the mask and wash yourself down.
There we go.
And again, I'm saying that is the level of precaution that I would recommend. There are people that are satisfied with not taking that level of precaution. But for me, I have a heart condition. For anyone over the age of 65, I would just say that's default. You have to do that.
And that is a long drive. We have a question from an allergy sufferer, which goes right to my heart because, as everyone knows, I mention it every call, I have allergies. Sandra is asking if you can differentiate between COVID symptoms and allergies. And this is something that did make me paranoid because I suddenly came across a bunch of articles where people said, I thought I had allergies and I had COVID.
Okay, and then there's a flip side of that people will just get scratchy eyes and a sore throat and sniffles and sneeze for days, and actually also feel somewhat like hay fevery, and then it's hard to differentiate that from the initial symptoms of COVID or the onset of COVID. So that's absolutely a problem that we're going to face. Aren't we somewhat through? No, we're not.
No.
Okay, so for Pennsylvania, at least my pollen season is May through early June. So we're done now, I think. I don't know about the rest of the country.
It depends on what the person is allergic to.
Okay. But yes, it's very easy to confuse the two, especially the very mild, symptomatology that, again, like I said, the majority of people who get COVID, who get SARS-CoV infection, it will behave a little bit like allergies. WebMD, what's going on? Oh, the flu season?
That's the allergy report for today in Wilkes-Barre.
Is that high, yellow?
High is yellow.
Okay.
Whenever any of these is in the moderate, well, yeah. I hate my life and want to not leave.
Do you take anything for it? Do you take cetrizine or any of those, Zyrtec or?
I mean, I try not to take.
I'm sorry to cut you off. One key differentiator is fever. Okay, if you hit a 101 fever, okay, you definitely need to get tested. Okay, that's the key differentiator. And then I want to go back. I forgot to finish one part of Carol's question. Using the lav in the aircraft. Just bring hand sanitizer, please. Your own hand sanitizer. So when you go in there and you have to touch something to wash your hands, when you're done with that, because I don't know the reliability of the soap and all this other stuff, 70% or higher alcohol content in a little bottle of hand sanitizer when you're traveling is great. Okay, it's a good thing to have. As far as the air circulation in the lab, it's the same risk. So keep your mask on when you're in the bathroom, in the aircraft at all times. Okay.
Hey, Sanjay?
Yeah, go ahead.
Yeah, the only season where there's not allergies in Texas is December to February.
Oh, okay. All right. Winter. Yeah. Okay.
Yeah.
I'm not dead.
That's the too late device. I call it the too late device.
Too late. I think
if you're going to be 3 feet, if you're going to be 3 feet away from someone, okay, that's close enough to put that up to somebody's forehead. All right, it's too late.
I think we're all caught up with questions.
Okay. All right. So the remaining topics are. Does anyone have any stories regarding going back to work. Am I sharing?
I mean, I can tell you, well, let me do this. So well, hold on. I don't have people's permission to put them on a live stream, but we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 people here at the game store. We had 12. We usually on a Tuesday, Thursday night have maybe 20. On a Friday or Saturday night we'll have 60, 70. But we've been observing limits on two fronts. One, we're using CDC guidelines as far as numbers. Also, staffing wise, if there's only one staff person on, there's no way one staff person can enforce or advise or help people more than 20 people in the shop at a time. That someone leaves, we got to wipe down the surfaces the chairs that they were at. Someone comes in without a mask, we give them a mask.
Yeah.
There's no way we can do that. So we've had to kind of adjust those numbers based on staffing. We have people that come in one door, out the other, processed. And I saw that. I went to the post office the other day, and they have two doors. One is an emergency exit typically, but that is now no longer, temporarily, just a regular exit. And they say, go in this door, go to the counter, and go out the close by emergency exit and walk around the building. It's been an interesting experience, and I think a lot of places are in that kind of environment.
Yeah.
And I think people going back to work, they're just happy to go back to work. So if somebody tells them you can come back to work, but you have to wear a mask, or you can come back to work, but you have to observe these specific guidelines, they're going to do it.
Heather has some stories from our hospital.
Okay, yeah, let's hear her.
Yeah, these are good because she, if you remember, she works the front desk at a plastic surgery.
Oh, right, yes.
Within a hospital.
Right.
So the hospitals are telling employees that they can come back to work 3 days after symptoms end. That's a little scary to me. 3 days after symptoms end. She's been back to work for 2 weeks. She works closely with an MA who refuses to wear a mask unless a patient is present. So she's not wearing a mask around her coworkers. Medical staff are some of the worst around here for taking this seriously. It's so odd.
That is odd.
So those are her comments.
Okay, so, all right. I don't know. The word blame is useless at this point. Okay. Now, what has to be utilized is kind of what is causative and what's not causative, right? So, keeping your circle of contact small, and using a mask in public is recommended because there's evidence that shows that lessens the causes of transmission. Let me put it that simply, okay? So there's arguments on both sides. There's one argument that says, oh, the mask isn't for you, it's for it's your community. By wearing a mask, you are protecting others just in case you are carrying it and you don't know. This is true, but let's not forget that there is some protective, there is some capacity of a cloth, even a basic cloth mask, especially 2 layers, or a surgical mask, which is engineered with 3 layers, to protect you from transmission. Would you tell Heather's husband, who works, AT&T, to go into a house without a mask in this era? No, it's ridiculous. But he's not protecting that household from him. He's also using the mask to protect himself. okay? So is it as protective as an N95 mask? No, obviously not, okay? But let's go back to what we were talking about. Duration and exposure, all right? The people who work in those environments are there for 6 or 8 hours, all right? That is a high risk unto itself. No matter how many people come in and out of that environment, whether it's 10 or 20 or 100, if you're spending 6 to 8 hours in one place, the duration and the opportunity for transmission are directly proportional. So that's that, right? So taking the mask off and putting it back on, and only when there's clients in front of you or something, it's kind of defeating the point, especially in a healthcare environment. Now, if you work in a game shop or I would want John to have the mask on if there's more than 10 people around him, okay? I would definitely want him to have the mask on and make sure that everybody else has a mask on if there's 10 people in that environment. Why? Because I don't know nobody knows how big the circle of contacts are for each of those individuals. All right. So they could be carrying and feel fine. They're asymptomatic. And then they're spending an hour or so with each other, playing games and being social, which is what we want. But we want to know that you're doing that with other people who are not carrying the virus or who have not been exposed in the last few days. Okay.
Well, and I think that's like that. So I went to get the test the other day for 2 reasons. One, I'm here all the time. So, I have staff that I bring in on a today somebody came in to cover during this, but I'm here all the time. So I see everybody that goes by, which has expanded my exposure circle tenfold in the last 2 weeks. Secondly, I wanted to tell everybody what happened, so because we keep telling people to go get tested on the webinar. So thought I should do that because
good.
Because reasons.
So tune in next week to find out John's test result.
Yes. All right, here, let's listen to this. This is the text messaging I've had with this mother, what we just talked about, right? We called the CDC helpline to ask whether or not their daughter could resume her normal activities now that she's recovered, okay? So her isolation began with the baby. So it's been about 8 days, right? So can she return to normal activities and go out and do stuff? So I told her about masking and staying away and making sure that at least 10 days go by, 10 to 14 days, all that. But this is what the CDC said. This is dumbfounding to me, okay? We called CDC helpline. They said if we culture her, okay, if the culture, right, I'll get into how that's done. We would be able to determine whether the virus was dead or alive. And if it was dead, then we could skip isolation because it's now past her being able to be contagious. Now, I just don't know, this is her speaking, I don't know how to have that done, okay? And they also said she should not have, I swear to God, they also said she should not have gotten tested. And then if she didn't, we would not have to be dealing with this all over again.
We believe
someone on a CDC helpline.
Wait, what? Huh?
Did you hear
what?
That? Did you
Say that again?
I have to repeat it?
I think what? What did?
Why would the CDC say she should not have gotten tested? Then we wouldn't have to deal with this all over again.
The best healthcare system in the world. There you go.
No, this is the CDC. It's not even Geisinger.
I know, but haven't you been watching the news? If you don't get tested for it, it's not a problem. I'm serious. This is, and I'm not going to say who said that, right? No one knows who said that.
We're not political here.
Right, we're not political here. And today he announced there's a AIDS vaccine that no one knows about.
No, but I believe her. I know that she's not saying this because she's being
But if it's
the mother's being political at all. She's just saying that
no,
we spoke to somebody at the CDC helpline, and they told us that she shouldn't have been tested. Okay,
well, that goes
her
back to the beginning of
11-month-old baby brother is positive. She's a teenager, and she lives in a household with a mother and a father. And the CDC is saying that none of these people should have been tested?
whereas they should all be tested.
Yeah, that's crazy.
It's
Bizarre.
going from top to bottom. I'm sorry. That's why we're at.
Because he works in a factory. Okay? I didn't ask her where she worked. I was not asking these questions. I was just trying to help her, make sure that everybody's safe. So, and the kid went to daycare. So we're talking about daycare, caretakers that should be tested. We're talking about finding out how many kids were in that environment, at least alerting their parents that they were in an environment where a kid got tested positive. And this is standard epidemiology 101. We teach this in India. We teach this to people we call barefoot doctors. They're village. We give them the title of village doctor because it makes them feel good. But it's basically like a corpsman in the Marines, right? You call him Doc. He's not an MD, but he's Doc, right? For that crew. So these guys are barefoot. We call them barefoot doctors because they're always in flip-flops. We teach them these things for cholera and for malaria and for anything, any infectious disease. We want to ask, okay, where was the kid? Did he get bit by it? Where did he get bit? Then go look for stagnant water in that area. Okay.
Sanjay's fired up. Don't say the H word, referring to a
I wasn't
drug.
going there. I wasn't going there.
I do have a drug question, but
Go for it.
Tell me. Oh, okay. So just so everyone knows, I keep Sanjay on his toes. I don't always tell him what I'm going to ask.
Okay.
So there's a BBC headline today that came out as soon as I woke up.
Okay.
And it was a low-dose steroid treatment,
Dexamethasone.
Yes. And the BBC titled it with a fantastic headline. It proves to be the first life-saving drug. What can you tell us about this?
I can tell you that
before.
John and I told you guys about this 5 weeks ago. It's part of the trimodal therapy.
Oh, I missed that. I guess
it's an anti-inflammatory.
I didn't recognize it from our trimodal. I have to do what that one our viewer did, where she put the name of the drug.
I think she's with us, Madeline. I think she's
Madeline,
with us. Yeah.
I need to do that Post-it note on my phone.
Yeah. So for different categories and different age groups, there's going to be a standard of care for kids for their anti-inflammatory treatment, and then their antiviral, and then what was the third one on our trimodals? Anti-inflammatory, immune modulators. So anti-inflammatory, immune modulator, antiviral. So for kids, we're going to use the set, and then for adults, and then for the elderly. And then also course of disease. So in early course of disease, you use a certain set of protocols. Like if they come in with fulminant pneumonia, prone them immediately, keep them off the ventilator, give them this set of anti-inflammatories, give them this immune modulator, and then if there's a good antiviral available, give them that. But we're learning that it's more important to keep them, oxygenated and keep them away from the cytokine storm. So keep their immune system nice and calm, keep them breathing, comfortably. That's more important than going after and attacking the virus with an antiviral immediately. So dexamethasone is again something we covered, I think, week 6 when we talked about the old standbys: low molecular weight heparin as an anticoagulant, and then the immune modulators like dexamethasone, and the basic things that we use in critical care medicine are actually the ones that are still effective lifesavers when it comes to COVID So that's great news.
So
I want to,
Terry,
guys, one thing I forgot I wanted to show you that's super cool. I was wondering if you guys had seen this or not.
Terry recognized that drug, so he is now the village doctor, and I have
Yes, he is. He's our barefoot doc. He's our tank top doctor.
I lost out on the job to Terry because I did not recognize that job. And then Madeline has two drug questions as well.
Okay, we're going to do the drug questions after I show you this cool thing. Ready?
After the individual breath into the breathalyzer, the species from his mouth, including the viruses attached to devices on this chip. We close the capsule that contains the chip, and then we transfer it to the spectrometer. And then we scan it for about 20 seconds, and then we have about 2 seconds of mathematical processing, and eventually we can say whether we have a corona carriers or we don't have corona carriers. This invention will be fulfilled at point of entries, maybe airports, cruise ships, companies. So we are going to position in those point of entries many machines. Each machine will have a throughput of about 4,000 people a day. We believe that we will do the validation within a few weeks from now, and then we have to go through the FDA process. So luckily, there is now a fast track of the FDA. So I hope that it will go within another month, and hopefully by September or October we will start to make systems. Since Israel is part of the startup nation, the reason for that is because we can find the power sometimes on a long-term basis at the forces of so many people that we know each other, and we have some good networking in the countries that big, so we can join forces in order to eventually come up with a solution and to validate the solution in a very short time.
Did you guys see that?
Earlier today, the White House Press Secretary Anderson was defending the fact that the president is going to hold his first.
Sorry.
COVID breathalyzer.
Yeah. So was the audio okay?
It was a little tough, but the subtitles helped.
Okay. So Ben Gurion University in Israel. So they've invented a rapid, like 20-second detection test. So, we need to get this kind of stuff up and running fast so that, it becomes ubiquitous, and then people know, okay, I got to stay away from other people for 10 or 14 days or whatever. And then just cut this daily 20,000 a day. It's just ridiculous. We just got to get a handle on where's the nidus of infection. Okay. And then just clamp down on it and stop the transmission. If we don't get serious about testing and guidance and having national strategy, and everybody gets the same advice, no matter where you are, if you're in Nebraska, Arkansas, South Carolina, Texas, Florida, Pennsylvania, we get the same advice. You get a positive test in your household, you got to test everybody. You got to find out where you possibly got exposed. You got to alert a health authority. The health authority has to do track and trace. If we're not doing this state by state, in every state the same way, and we're allowing states to do it whatever haphazard way they're doing it, we're never going to get control of this thing. Okay, and the real issue is there's going to be needless death. 80% of us are going to get it and go on with our lives. But 45,000 elderly are dead. Okay? I don't want another 45,000 dead in 4 months. I don't want another 1.5% of every 20,000 positive cases a day dying, because that's what happens. We know it happens. So we got to get serious about it. We got to, anyway. the drugs.
Okay, so Madeline has 2 drug questions, and then I kind of want to ask this Heather question again because I feel like it's COVID Breaking Bad.
Okay.
Okay, so Madeline, are statins now part of a recommended therapy? And her second question is, what about cardiac glycosides?
Glycosides, yeah.
Glycosides.
Okay, so so cardiac digoxin and okay, so interesting question. I would say that in some cases, you know, where there's some deficit, underlying cardiac disease, and the patient's deteriorating. This is a pretty advanced topic. Obviously, Madeline would ask this question. So this is an advanced topic. When there's a reduction in cardiac contractility, and that could have been caused by you know, myopathy, or it could be caused by congestive heart failure, which is secondary to the pneumonia. There are some indications to help the heart. Okay, so but I would leave that decision to a critical care doc that knows what they're doing and that has, you know, 10, 15 years experience with cardiac glycosides and dealing with a failing heart in those circumstances. And just pray to God that you're near like someone that knows what they're doing in an academic medical center. In general, trying to recommend those to a community medical center to deal with a COVID case probably would do more harm than good. So we would stay away from that. We would press the trimodal therapy, press the immune modulators, anticoagulants, anti-inflammatories, and then obviously if we can get in the tocilizumab or the leronlimab, which are the antivirals, bring the viral titer down as fast as possible. These other drugs are really in specialized cases and would not be used in 95% of the patients or more. What was the other one that she asked about?
The cardiac.
Statins. No,
Statins.
I don't think there's an indication for statin here. That's you know, statins are HMG CoA reductase inhibitors. They act on specifically in the liver enzymes. I would stay the heck away from those things. I don't know. Maybe Madeline could send us something that she might have seen, but I haven't seen any indication for statin usage.
Okay. So Heather's question, I really want to ask because I want to set it up like a Netflix plot because I feel like that's what it is. Heather, who works in a plastic surgery office,
Mm-hmm.
whose husband, Charlie, who has long brown hair and is living in the garage, she wants to know if she should dose him with aspirin and Pepsid because she already takes it, but she kind of wants to give it to him too. And then she's also asking about CBD. So should we give Charlie, who's living in the garage, CBD, aspirin and Pepsid?
No, unless he's really anxious, I don't think there's any need for CBD or even THC. Unless
what if she's
unless
anxious?
it's legal and he will make him feel better and less anxious, then go ahead and do that. But
what about giving it to her?
Yeah, I would recommend it for her, definitely. To help with her anxiety.
Heather, I would watch that Netflix special, Charlie Living in the Garage.
It's hard to say. Like, for example, aspirin acts on a clotting cascade, clotting in a different way than warfarin does, or low molecular weight heparin does. Okay, so they're all different types of anticoagulants. Now, if he starts spiking a fever, yeah, but as a prophylaxis, I don't know. I mean, it's just not. They're not going to harm, especially if you're going to give him like 81 milligrams of aspirin, like a baby aspirin. It's not going to harm him. Is it going to prevent him from eventually getting the symptoms? No, definitely not. And then as far as the Pepsid, which is the active ingredients, famotidine, yes, there's a lot of evidence that famotidine can help with the infection cycle, okay? But again, I can't as a professional tell you, yeah, I know that here's the mechanism of action, here's the pharmacokinetics, and here's the reason why. Most likely famotidine is indicated. I can't do that. Is there anecdotal evidence, just like there was for the H word? Yes, it's out there. There's anecdotal evidence that it could be of benefit, but that doesn't mean you buy 29 million pills and stockpile it. We don't know. And because we don't know, it's not necessary. Now,
Heather, were you going to hide it in his food? Oh, wait, don't answer that. We don't want to know.
So the Merrick protocol, which brings together the things that we've been talking about, is out of the Virginia Commonwealth University, and Dr. Merrick is a famous builder or disseminator of protocols in intensive and critical care medicine. And he has now said, okay, there's a protocol for COVID, and here it is, and it involves the trimodal therapy. But he's also included the opportunity to give famotidine in there, in the mild cases. Well, mild for hospitalization, okay? There's mild, there's moderate, and there's critical, right? So mild could be 104 fever that refuses to subside, but breathing is fine, patient's oxygenating, okay? You know what I mean? So there's different gradations here. As far as your husband, completely asymptomatic, extremely anxious wife, I guess we would recommend THC, CBD, and for anything else right now. Okay.
We feel for you, Heather. We feel for you. Tune in next week to find out how Charlie did in the garage.
Yes.
We'll also find out if Heather brought a bong. So.
Any further questions? And then we can, John, what are your thoughts? Anything we're missing?
I have no thoughts. My thoughts were removed
I think we're caught up.
by this device. No thoughts.
Yeah, Terry, go ahead.
Yeah, there's on Facebook, Penny asked, again, another question about supplements, and she's heard about the vitamin D3, elderberry, turkey tail mushrooms. These are things besides the vitamin D, I haven't heard it before.
Mm-hmm.
And she asked, I think you covered about masks pretty well. But just real quick, if you could, on the supplements and...
Sure. So one of the things that we did cover is that there are appreciable benefits to taking supplements. So the supplements that we know that have strong benefit are vitamin C. Vitamin C is a water-soluble vitamin, so that you can take that, in large quantities, and your body will use what it needs and what it wants, and then it is removed since it's water-soluble, it's removed in the urine by the kidneys. Vitamin D is not a water-soluble vitamin. It has a natural mechanism of being produced in the skin cells. So when you are exposed to, natural sunlight, there's a specific wavelength of sunlight that helps with the conversion process of the various forms of vitamin D, the most important of which is vitamin D3. And so that has appreciable benefits to the immune system, to calcium metabolism, and a lot of other neurohormonal things that enhance your health. Okay, so that's those are the two recommended vitamins that you could use, but you have to use them in normal quantities. So the recommended daily allowance of vitamin D that you would get in a multivitamin, or that you would get in a supplement that's just pure vitamin D3 or D2 or whatever. And then, 1,000 milligrams of vitamin C or 2,000 is fine, but you don't want to go overboard with any of those things. The other thing that is important to note is that elderberry and all of these, we call them phytochemicals because they come from plants. They're plant-based flavonoids. They have a anti-inflammatory effect naturally. Okay, so people who consume a lot of this, will see benefits in their joint health and in their ability to walk 1 or 2 miles and then recover quickly. So when you include natural flavonoids in your diet in a higher quantity, it just means that the normal inflammatory and repair processes of your body are enhanced and accelerated. Are any of these going to prevent you from getting infection? No, none of these are prophylactic. Okay, they have no known or appreciable or even well-studied preventative effect. But if you have adequate quantities of vitamin C, vitamin D, flavonoids, and other minerals such as zinc, manganese, magnesium in your body, it just means that your body is ready to handle an infection better than not having it in your body. Okay, so I hope that makes sense. So to be well nourished is a better condition for you to fight off a disease than not be well nourished. So
what you're saying is that if Karen and I don't want to go to the gym,
yes,
but we want to pretend that we can walk 2 miles easier, we should drink elderberry wine.
Wine? I don't know.
Well, that's what Karen, you in? We're in.
Yeah, we'll have to see about the wine thing. I think, well, wine in general is good for the liver as long as it's taken in small quantities. It enhances the smooth endoplasmic reticulum.
Bernie agrees.
So that increases your ability to detoxify. But yeah.
Your dog agrees.
Yeah, Leslie wanted to know if that's also true for margaritas. So
that's a much higher alcohol quantity. So we're talking about what, 12% for wine on average, or 14%, and then what's tequila?
I think I'll just tell her no.
Yeah. Yeah.
All right, we had a lot of questions tonight. It's almost as if America needs guidance on COVID-19.
Crazy.
Yeah, I mean, I mean, we haven't had a task force. Not that the task force was very effective in disseminating protocols or guidance. It was more just, this is how we're doing. We're tracking at this level nationally. So all we really got was some numbers and some, blah, 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 and what you guys should do to try and prevent spread. But if we had a task force that was telling us, if you get sick or if somebody tests positive, you need to do these things and you need to call this number, and or even guidance for healthcare workers. So your chief medical officer of your hospital system could call in and attend a webinar, and then they'd receive national guidance on how their health system should deal with this, on a weekly basis. Why aren't we doing that?
It would be helpful if, the states that are still doing their own little updates just push masks. I mean, every country that's been successful with this thing, one of the things they had in common were the masks.
Yeah.
And we are falling so far behind. I mean, last week I joked about Texas was going to overtake Pennsylvania, and we're 10,000 ahead of you now in a week.
Wow.
10,000. So Texas is going to be like Arizona in a couple of weeks.
How can we trick Texans to wear masks? Is there a trick?
Tell them that the people on the left don't like them.
Yeah. find a way to tell them that
Those damn libtards hate it. Sorry, Sandra. Sandra got upset with me a couple of weeks ago. I got political. And I was texting with her to get her information about this, and she's very sweet.
She's wonderful. We were
she's a
texting
very
a lot
nice
this
lady.
week. Yeah, over the weekend. Yeah,
She's a very
awesome.
nice lady, and you can yell at me anytime, Sandra.
All right, so that's the homework for the attendees next week.
Wait, we gotta. You know what? Wait, this is great. I hope she's okay with telling you guys why she wasn't able to join for the last 2 weeks. She joined a. She joined a trap shooting group.
All right.
So, yes. So she's been getting fresh air. She's been getting out, and exercising and right. So all good there. So. I said trap shooting. Yes. So we're closing out, John?
You're all insane. You're insane. You're insane. And you know what happens when you all become insane?
John has to step in.
I hit this button and it goes.
Okay.
All right, everyone. We are at the end of our time here. We are going to hang out here a little bit tonight. So if you'd like to stick around, Dr. Doshi will stick around and answer any other questions that we have. But our live stream is ending. We will be back here, I think, next week. Same time, same place. We will see you then.
Okay.
Good night, everyone.
Thanks, everyone.